Hi guys. Today we're going to work on chapter 42, which is basically an explanation of why we do transabdominal and transvaginal scans of the female pelvis, and get you more familiar with that. So before we start scanning, there's multiple things that we need to have the patient do and some information that we need to take. One of the ones that you always want to ask is, what's the date of the patient's last menstrual period? And the reason that we like to do this is because the ovaries and the endometrium, they look and different depending on what part of the cycle the patient is in, as you learned in your last chapter. You also want to ask how many times they've been pregnant, which is gravity, and parity, how many babies they've had, if they're on any hormone regimen, the symptoms that they're having right now, any family history of cancer, if they've had pelvic surgeries. That's a big one. You want to make sure that they still have everything. There's been times when people don't tell me they have had their ovaries, and then I get in there, I'm like, I can't see your ovaries. And they say, yeah, I don't have them. And I was like, oh, that would have been nice to know. And also, if they've had previous tests, what were the findings of those? So the pelvic sonogram is split into two parts. The transabdominal approach, which is where the transducer is scanned across the lower abdomen after warm gel has been applied, kind of like, the abdomen scans you're starting to do. And the transvaginal approach, which is an internal ultrasound exam similar to a pelvic examination. And the bladder is empty for that. With the transabdominal approach, you want to make sure that you have a full bladder, because that will help you be able to see the uterus and ovaries. So when you guys are practicing on each other, you need to fill your bladder up, drink 32 ounces of water like an hour before, and that will help you guys have good windows to be able to see the uterus and ovaries. This is a picture of the transabdominal ultrasound. If you can see that the sonographer is on top of the belly and he's looking at the ovaries, and this big black hole right there, that's the bladder. So this patient's bladder is full. This is a transvaginal ultrasound. And the probe goes into the vagina a little ways, but you can see so well. Now on the picture of the right, this is like a little phantom dummy, and we have one of those. So when I get to see you guys in a couple weeks, I'll show you so you guys can start practicing. And that gives you helps you learn how to maneuver the probe to get a better view of the uterus and ovaries with the transvaginal ultrasound. What do we look for on a pelvic ultrasound? Well, the uterus is a huge one. You want to document the uterine size, shape, and orientation. Orientation meaning retroverted, anteverted, like what we talked about. We want to look at the endometrium, measure the thickness. We want to look at the myometrium, which is the muscular layer, if you guys remember, of the uterus, and the cervix. And the vagina serves as a landmark for the cervix and lower uterine segment. So we'll measure the uterus in length from the fundus of the uterus, which is the very top, to the cervix. Then the anterior posterior depth measured is from the anterior and posterior walls. Then we will turn transverse, which you guys have probably been working on a little bit, and you will get a width measurement. Cervical diameter, sometimes with pregnancy, we'll measure those, but you won't measure the cervix in a regular transabdominal pelvic ultrasound where the patient's not pregnant. The endometrium is definitely analyzed for thickness and echogenicity, and we measure that. And then we look for the myometrium to look for the changes, echogenicity, and if the patient has any fibroids. The ovaries are identified anterior to the internal iliac vessels, And we'll look at the size, shape, contour, and echogenicity, the position relative to the uterus, and the ovarian size. If there is a large cyst, we will also measure it by little follicular cysts. That's really normal, so we don't tend to measure those. Look for the cul-de-sac. Make sure there's not too much fluid. A little bit, like we've talked about, is okay, but too much is you would want to mention that on your report. So here is the sonographic technique. So on the lower belly, the transducer is placed. This is the acoustic beam and the acoustic window. It goes, when the bladder's full, that creates a beautiful window for the uterus to be able to see. And this is just what it looks like on an anterior approach. So bladder, this is the vagina coming in here, the cervix, this is the endometrial canal, the fundus. So you'll measure from the top of the fundus to the cervix here. Then for anterior posterior, you'll measure from there to there. When a mass is found on a sonography, you want to make sure that you measure it. You are telling in your prelim report, the location of the mass, and if it's well-defined, ill-defined, irregular borders, and the consistency. Is it cystic, complex, cystic, and solid? So you'll want to write all that, but specifically like if it's a ovarian mass or a fibroid. So this is actually a picture of a transabdominal ultrasound. And when you guys scan, if your bladders are nice and full when you practice, this is probably what you'll see. So this right here, this is the vagina coming in, and this is the cervix. So when you measure, you'll measure at the tip of the cervix to the fundus of the uterus, and then an anterior to posterior measurement here. And that's a beautiful picture of the uterus. This big black hole, this is the bladder. This patient's bladder is crazy full, but you can see that you can get a very nice window of looking at the uterus there. This is just showing another image of the transabdominal ultrasound. And measuring the uterus again, anterior to posterior, right there, and sagittal length measurement. When you turn transverse on the uterus, it's going to appear more circular because you're looking at it in a transverse view. So you're kind of cutting it through like a slice of bread. So you're going to measure from one side to the other, and that'll get your width. So when you're doing a transabdominal pelvic ultrasound, the protocol will be, which I will put the protocol on your, if it's not already on there, on your Canvas site. You do a midline image to see the distended urinary bladder, the uterus, endometrium, cervix, and vagina. Then you'll measure. Then you'll go to the right to see if there's any masses on the right side of the uterus. Then you'll angle back and go to the left. And then you'll look at both the right and left adnexal areas in the true pelvis. This is just another image of the uterine measurements. So length, anterior. Can you see how this bladder is not as full? And so you aren't able to evaluate as nicely the fundus of the uterus. So that's why it's so important to have a full bladder, have the patient have a full bladder when you're scanning to get the optimal images. This is, again, the transverse uterus. These are little ovaries. A lot of people, students and sonographers, really struggle getting the ovaries on transabdominal because they're so small, and their echogenicity sometimes can just be almost exactly the same as the surrounding bowel muscle. So they're difficult to, it takes practice to be able to identify them. In a transverse ultra, once you get done with all of your sagittal images, you'll turn transverse and you'll start at the inferior cervix, and then you'll just work your way up from to the patient's head, just slow angulation of the probe. And you want to see a low pelvis at, and that's just going to show you the urinary bladder, vagina, cervix. Then you're going to go up a little bit higher to get the body of the uterus and look for the ovaries, and then the fundus, the uterus, endometrium, and still trying to evaluate the ovaries. This again is a transverse uterus, and this is the beautiful endometrium here. This looks more like a secretory phase as it's really echogenic. So once you do the transabdominal ultrasound, you'll want to do the transvaginal if you did not get everything. Some places even require that you do both scans. Where I work, PRN still, we usually just do the transvaginal because it's most of the time a better image. If I can't see everything, then maybe I'll do the transabdominal. Some places start with the transabdominal. If they get everything, they're done. So it kind of just depends on what your clinical site does. I personally love the transvaginal ultrasounds because I feel like I can see so much more clear because you're closer to the uterus and you're not having to deal with different layers of the patient, like the fat, the muscle. So it's just a better view. So you'll have the patient empty their bladder for this. And this is showing that the probe goes into the vagina, and the acoustic beam shows the whole uterus here. And this is what it looks like on the screen. Then you will turn the probe to the right, and you will get this beautiful transverse image of the uterus. Now this, it might be on your test, so just to make sure that you know, when you transverse sagittal scanning with anterior angulation, so you're moving the probe, the part of the probe that you're holding down to get a better view of the fundus. So when you anterior angulate, when you make the probe go more anterior, you'll see more of the fundus, but you'll be pushing the handle down very gently. When you push the handle up, that'll be more posterior angulation, and that'll give you a better visualization of the cervix and recto-uterine recess. Then you can turn the probe 90 degrees to record the transverse images, and that's always to the right. So if you're holding the probe, you'll rotate 90 degrees to the right, and that'll get your transverse image. Look how beautiful this uterus is. Can't you see so much better than the transabdominal? Look how clear you can see the myometrium and the endometrial canal. So then you'll do kind of the same thing protocol as you do with transabdominal. So you'll go to the left, and then you'll go to the right. Just make sure there's no masses, everything looks good. Then you'll rotate the probe, and you'll start going, you'll pull the probe up a little bit to be able to see the cervix, and then you will just slightly angulate it down posterior to get more of the fundus. So what I'm talking about is you start up high with the probe to get the cervix, which is actually posterior angulation. It's kind of confusing. And then you'll continually push the probe down to see more of the fundus, which is actually anterior angulation. So it's kind of confusing. It's easier once you are just kind of scanning. It's easier to explain. So, you know, ask Brooke or Bree if you guys can get the phantoms out so you can start working on that. So this is just showing images of transverse. This was a beautiful mid where you would measure the width. And this is like an inferior uterus. And then that's the cervix. Look how good you can see the ovaries. The ovaries, once you get them, are so much easier to see on the right, or on a transvaginal. This is the right ovary, and there's just a small dominant follicle on there, which is totally normal. And then look at the left ovary. Definitely easier to see than transabdominal. So for a sagittal uterus, you're going to take images of the cervix and fundus, and then you'll slowly angle to the right and then slowly angle to the left and pull the probe out just a little bit to image the cervix. This is a retroverted uterus. So the cervix is going to be on your left hand of the screen and the fundus is going to be on the right, but yet you can still visualize it so well. In comparison, keep this in your mind. And this is an antiverted. So the fundus is on the left and the cervix is on the right. And you'll need to be familiar with this for your test. There's one more image. And if you can see the endometrium, it looks like that 3-line sign. Do you guys remember what phase that is? That's proliferative phase. Then coronal or transverse. Technically it's coronal, but we usually just say transverse. So just remember it as transverse uterus. Rotate transducer 90 degrees and image the uterine fundus, body, and cervix. Look at that beautiful image. Then you'll look at both ovaries. So you'll go sagittal to the right to see the right ovary. You'll take some images, do a color image, and measure the long axis. Then you'll turn the probe 90 degrees to get the transverse measurement, or the width. Seems pretty easy, right? It takes a while, but you guys are gonna get it. Sometimes you can see the bony pelvis too, and bow. And you will be able to see some of the muscles, especially those levator ani muscles that help hold the uterus up, that's the reason why we need to do Kegels, to keep that uterus up there when we're older. Sometimes those can be seen. The rectus abdominis muscles you can see transabdominally, and they just look like echoic structure. So I'll show you this. So this is bow. There's some muscle here and some fat. This is totally normal. If you guys scan yourselves, you'll see these muscles and the layer of fat and your bow. That's just how we're made. This is a transabdominal transverse image, and these little hypoechoic areas here are the levator ani muscles that you will see when you're like doing a inferior uterus. And this is just another pelvic floor muscle. So these little striations here. So pelvic vascularity, we don't do too much with vascularity in general ultrasound. At the hospitals, you're not going to be Dopplering the ovarian arteries unless there's a concern for torsion. So although your chapter does go over this, I want you to just not worry about this right now. We will talk more about this in OB2, where it does matter. So just be familiar that there's different ratios to measure pelvic vascularity, but do not spend too much time on that. What I do want you to be familiar with, though, is what the arteries are that are giving the blood flow to the uterus and ovaries. And the uterus is actually very vascular. It's kind of crazy. We'll talk a little bit more about that in just a second. But let's remember the 3 layers of the uterus: the serosa, the myometrium, and the endometrium. You will need to know this for your test. The inner layer is the endometrium, which we talked about last chapter. And the thin outer layer is separated from the intermediate layer of the arcuate vessels. Now, sometimes when we get older, those arcuate vessels become more calcified and appear echogenic, like little echogenic foci. So that's a pretty normal thing for an older uterus to have those. So you will see arcuate vessels in the periphery of the uterus, and that's totally normal. And the radial arteries arise from the multiple branches of arcuate arteries and then travel to the deep layers of the myometrium and endometrium. So it's just such a vascular little organ. Here are all of the vascularity of your uterus. Now you can also Doppler your own uterus and see these beautiful vessels that supply the endometrium. And this is what I really want you to be familiar with. The uterine artery coming in here, then the arcuate arteries is the first branch, then the radial arteries is the second branch that is feeding the endometrium. And then you have these little spiral arteries that is what sheds every month and causes all that fun stuff every month. The body is separated from the cervix by the isthmus at the internal os and identified by narrowing of the canal. Now, we talked about that a little bit, the internal and external os, and in one of the discussions, I put a picture of that, and that's just the anatomy of the cervix. One thing that you will see are Nabothian cysts within the cervix, and these are just benign and very normal, and they're of no clinical significance. So we don't usually measure them unless there is like a ruptured cyst. This is what they look like. They're on the cervix, and they look like these little round balls, like little cysts. And if you see those, yeah, those are Nabothian cysts, but I don't ever really mention those in my report because they're just so normal. We will look at the cervix though, which is this whole area right through here. So the cervix is usually fixed midline, but the uterine body is mobile. It may be oblique on either side, might be anteverted, might be retroverted, might be flexed. You know, what we kind of talked about last time. The uterus kind of just does what it wants. Most of the time, the uterus is anteverted and antiflexed, but sometimes you'll get a retroflexed, retroverted uterus, which we've talked about. This is a retroflexed uterus. Again, the cervix is going to be on the left side of the screen and the fundus is going to be on the right side of the screen. So it's just flipped. But you can still evaluate it really nicely with transvaginal ultrasound. This is just we're going over it one more time, the uterine measurements. So from the fundus to the cervix, this long area, you remember that vagina is like 9 centimeters long. It goes like a tube, and then the cervix is going to be the first part that you measure, and then the fundus is going to be the tip there, and that's going to be your sagittal length. This is the transverse image, which you'll just turn the probe in transverse to get that image. And the sonographic appearance of the endometrium, we're talking about that again. You guys kind of remember that from last chapter. But depending on where a patient is in their menstrual cycle is how it's going to look. They administration, it's going to be pretty small, thin line, and it'll reach around 4 to 8 millimeters in the proliferative phase. Here's that pretty image again. So this is right before period time, and it's nice and thick, and then the body sheds it. It's a thin line. Then the estradiol helps produce a very beautiful proliferative phase of the 3 lines, and that's usually from day 5 to 14. Then it's very nice and ready for ovulation around day 14. And then 14 through 28, it gets very thick again with posterior acoustic enhancement. And this occurs in the secretory phase, which is from day 15 to day 28. And this is kind of what that goes over here. So early on in the proliferative phases from day 5 to 9, the endometrial canal appears as a single thin strip. But as it goes from day 9 to 14, it creates this complex 3-line sign again. We're really beating this into you, but it's very important. I would say usually the endometrium around day 14 is going to be about 10 millimeters, 1 centimeter, and that's pretty normal. We don't want an endometrium greater than 1.4 by the end of the secretory phase. If it's thicker than that, then it is considered abnormal. Day 15 through 28 is the secretory phase, or the luteal phase in the ovarian cycle. And this is when it reaches its greatest thickness and echogenicity. The endometrium is going to be 7 to 14 millimeters, which you'll need to know that 14 millimeters is the cutoff of normal during the secretory phase. And it's going to be echogenic, and there's going to be posterior acoustic enhancement during that time. If you think about it, the endometrium's job is to create a very nice fluffy home for a zygote if it decides to go. So that's why it's getting all that beautiful vascular blood flow, and it's just getting ready for that baby to, that's the uterus's, that's the whole reproductive system's goal, is to get pregnant every month. This is a secretory phase. Endometrium, you see it's echogenic. This is a menstrual phase. Now I should have asked you what phase this was. See how thin that is? This is the menstrual phase. Okay, you ready for your next quiz? What phase is this? 1, 2, 3, proliferative phase. If you look at the measurement here, it's 7 millimeters. So that's probably late proliferative phase. So I would say from day 9 to 14. What phase is this, guys? The secretory phase, you got it. See how nice and thick that is? 1.23 centimeters. So the normal fallopian tubes are not going to be seen transabdominally and transvaginally unless they're dilated, filled with fluid, which occurs in pelvic inflammatory disorders. So they're difficult to see. You're not going to see a normal fallopian tube, which is good. The ovaries can be very mobile and can be all over the place, especially if a patient's had a baby. Those ovarian ligaments have been stretched out. And so one ovary might be close to the uterus, the other one might be way high up in the pelvis. And that's kind of the difficulty with evaluating ovaries, because they're just in different spots. But there are some landmarks that we need to know, and this is very important for your test. The ovary is located just lateral to the uterus and anteromedial to the internal iliac vessel. So if you think about that, it's going to be higher up than the internal iliac vessel and medial. So it's not going to be any more lateral than that vessel. So if you see that vessel, you've gone too far. most of the time the transvaginal transverse images are the easiest to find the ovaries. So sonographically, a normal ovary appears as a medium level echogenic structure. The follicular cyst may be seen peripherally in the cortex, and appearance changes with age and menstrual cycle. So young kids, young girls have a lot of follicles. But postmenopausally, the ovaries are going to shrink, and you're not going to see as many follicles on them. They're retired. They've done their job. This is a normal ovary with the little follicles. Those are totally normal. This is a normal ovary transabdominally. So this is a transvaginal. Look how pretty you can see it. You can still see this, but look how far away you are from it. Just can't evaluate it as well. They like to calculate the volume of an ovary because if it's too large, that can be considered possibly polycystic ovarian syndrome, or if there's a mass, could be a sign of ovarian cancer. And how they calculate the volume is the length, thickness, and width. So length, AP, and width. And then the computer does something with this number here, and then it will determine a volume for you. Like we've talked about, the rectouterine recess is the most posterior and inferior reflection of the peritoneal cavity. So you will see some fluid within the posterior cul-de-sac different times of the patient's cycle. Totally normal. There it is. This is the uterus. Look how big that bladder is, nice and full. And then you'll see a little bit of fluid. And yeah, that's pretty normal. You will also see some gas and fluid filled bowel while you're looking at this, and it sometimes is difficult to determine if this is bowel or if it's a mass. But one thing that we like to look at is peristalsis, which is movement of the bowel. And sometimes if I'm having trouble distinguishing between a mass and bowel, I will watch to see if the bowel moves or the contents in the bowel moves. If I see that, I'm very aware that that's just bowel and it is not some kind of crazy ovarian mass. So all this echogenic area here that's shadowing is bowel. Now, the reason it looks so shadowy and we can't really see it transabdominally is because it's gas filled. And if you guys remember, ultrasound can't travel through gas or air very well. So you're not going to be able to evaluate it very well that way. Sometimes we have to do, for polyps of the endometrium, which we'll talk about a little bit more, sonohistography, and your chapter covers this just a little bit. I wouldn't worry about it too much. We'll talk about it later on. But what they do is they put sterile saline solution in the endometrial cavity, and it makes there be fluid in the endometrium, so it's easy to evaluate if there is a polyp or some crazy area of thickening. And this is what it looks like. Fluid within the endometrial canal. We also do 3D ultrasounds and some probes. If you're lucky, when you go to clinicals, you'll get a 3D probe that will allow you to look at the pelvis and the uterus in 3D. And this is very good for evaluating congenital anomalies and looking at the endometrium. And that's what this is like a coronal view. So if you cut the uterus in half, so you can see this beautiful endometrial canal. And this is what it looks like on 3D. So you can really see how you could evaluate the uterus. Another great thing is with 3D, you can, once if a patient has a intrauterine IUD device for birth control, you can see if it's in place very good with this 3D ultrasound. This is what it looks like when you're about to do a 3D. You line it up with the endometrium in 3 planes, and then this is what it looks like at the end. Not all places have this, but you might get lucky. All right, well, that's it, guys. If you haven't, we'll do our discussion for questions again. But if you have any other questions, just let me know or email me. And I hope you have a good week. Thanks.